the rheumatological practice, all of us would be seeing either polyarticular or oligoarticular arthritis, which is usually 2, 3, or 4 joints involved. If there are more than 4 joints involved, we call it polyarthritis. In a OPD, in a busy OPD, there will be many other differential diagnoses that one has to consider when seeing a case of polyarthritis. The patient could be a case of multifocal osteonecrosis, periosteitis, primary bone disease. This can all present just like polyarthritis, with some differences, of course. Muscle disorders, polymyalgia rheumatica, neuropathies, tendinitis, bursitis, this could all present as a varied form of polyarthritis. And of course, we have the functional patients with functional complaints and fibromyalgia, which can be very misleading. And many patients could actually be malingering. Because we work in industrial townships and we had a lot of patient population who actually work for the industry, many of them would be malingering. So this is a very common symptom which you find in OPDs where the patient care is free of cost. I mean, it is the company that takes care of all the expenses. There are many cases of oligoarthritis that could be presenting to us, and sometimes they would confuse us with polyarthritis. The common causes of oligoarthritis, however, are spondyloarthritis, psoriatic arthritis, the Lofgren syndrome seen in sarcoidosis, Ponson's disease, and certain subsets of juvenile arthritis. But what we are talking about is acute polyarthritis. There are a lot of patients with acute polyarthritis who could be presenting to us, like, for example, rheumatoid arthritis, which is the de novo default disease that we generally explain when we talk about chronic arthritis. Patients with SLE, patients with psoriatic arthritis, connective tissue diseases, they could all be presenting with polyarthritis. Septic arthritis, Rita's disease, certain viral arthritis like the very common parvovirus related arthritis, inflammatory bowel disease related arthritis, sarcoidosis, serum sickness, certain hematological conditions, and of course palindromic rheumatism could be the other causes that we encounter while looking at cases of acute polyarthritis. The most important thing when we are seeing a case of polyarthritis is to determine whether the polyarthritis is inflammatory or non-inflammatory. This is one of the fundamental requirements as we need to proceed forward as to make a diagnosis. So we look for early morning stiffness. If the early morning stiffness of the joints lasts for more than an hour, it is likely to be an inflammatory polyarthritis. And if activity improves symptoms, and lack of activity worsens symptoms, then the chances are that the joint that you're dealing with is inflammatory. The inflammatory joints will have spontaneous flares where the symptoms could just increase for a certain period of time and then settle down. And there will be constitutional symptoms associated with inflammatory polyarthritis like fever, there would be loss of weight, there would be fatigue, maybe weight changes. So we look for constitutional symptoms. So it is important to differentiate inflammatory from non-inflammatory, no doubt. And luckily, most of the criteria are clinical, and clinically we can determine whether a joint is inflammatory or not inflammatory. Next slide. So when we look at a case of polyarthritis, we need to determine whether it's an acute polyarthritis or a chronic polyarthritis. The second thing, of course, is that whether it's an inflammatory polyarthritis or a non-inflammatory polyarthritis. We also look at the past history, the personal history, and the family history. These are important when you're dealing with the diagnosis. In the past history, you could have history of similar symptoms somewhere in the past, which has lasted for a certain time. The patient has either taken treatment or not taken treatment, as sometimes some of the rheumatological conditions would settle down even without treatment. There would be a natural remission. So we need to take and consider the history in the past. Besides this, we need to take a personal history because smoking, of course, is closely associated with rheumatoid arthritis in particular. There could be history of HIV. There could be other personal history which we need to consider. And of course, those people who are adults who are sexually active, they will throw some light on reactive arthritis like Reiter's. And family history is important, particularly in conditions like rheumatoid arthritis, where you could be having somebody in the family one generation or maybe a couple of generations back. So we need to take all the history and consider the diagnosis. We also need to look at the various systems because there could be multi-system involvement in polyarthritis, and also look at extra-articular manifestations. Finally, we need to look at the pattern of the arthritis and the topography, how the progress of arthritis is, how the progress of the joint involvement is taking place, because that will give us important clues on the diagnosis. So, among the common causes of acute polyarthritis, rheumatoid arthritis could also present as acute polyarthritis. Of course, it is more commonly known for the chronic, deforming, functionally disabling arthritis, but it can present as an acute polyarthritis. There are other conditions like lupus, like psoriatic arthritis, connective tissue diseases, and of course systemic vasculitis, which could present as polyarthritis, acute polyarthritis. Septic arthritis is a classical example of acute polyarthritis, and gonococcal arthritis, of course Reiter's, viral arthritis, inflammatory bowel disease related arthritis. This could all present as acute polyarthritis. And sometimes conditions like serum sickness, sickle cell disease, and of course palindromic rheumatism. So these are pictures of one of my patients where you can see that the patient actually came with acute pain and polyarthritis. Patient was already an established case of rheumatoid arthritis with joint swelling and deformity, as you can see. And when you actually review the system and do a systemic examination and look at extra-articular manifestations, you will get many other clinical clues. The skin, the eyes, these are important parts of the examination because we can get many important clues from examining these systems. In psoriatic arthritis, we would get several skin lesions, so we need to examine the skin very carefully. In lupus, of course, we get the typical facial butterfly rash. Mucosal ulcers, there will be alopecia, and there would be vasculitic skin lesions. In Behçet's, you would get oral and genital ulcers. In dermatomyositis, patient could be having Gauthron's papules on the hand, heliotrope rash, the mechanic's hands, and the shawl sign. In scleroderma, we could come across Raynaud's phenomena, telangiectasis. As a patient of sarcoidosis would present with lupus pernio. And in urticaria, patient would come to you with vasculitis. And when you further look at the systemic examination in rheumatoid arthritis, a patient could present with epistaxis, scleritis. In spondyloarthritis, we could come across iridocyclitis and uveitis. Systemic lupus, patient can present with retinal lesions and other systemic vasculitis. In GPA, we could come across proptosis, which happens with retrobulbar lesions. A saddle nose is commonly seen in GPA. In Reiter's, you find the urethritic form of reactive arthritis, and in inflammatory bowel disease also we come across peripheral polyarthritis and some patients with erythema nodosum. So there are a whole lot of findings that we get while examining the various systems and also looking at extra-articular manifestations. Examination of the peripheral and the central nervous system is important in SLE, antiphospholipid, for systemic vasculitis and Behçet's. The lungs will have significant changes in rheumatoid arthritis, the rheumatoid lung, which you all are aware of, connective tissue diseases, ankylosing spondylitis, and systemic vasculitis. There will be cardiac changes in antiphospholipid as systemic lupus, scleroderma, and dermatomyositis. So the pattern of joint involvement is very important in clinching a diagnosis. The joint involvement could be additive. that means a set of joints are involved, and then there could be further sets of joints that could get affected. As we see many times in rheumatoid arthritis, the patient is initially coming with a unilateral polyarthritis, maybe in the upper limb. Then after some time, you follow up and see that the patient has bilateral polyarthritis, maybe both upper and lower limb together. And sometimes you see a patient having an intermittent type of joint involvement, like for example, in a gouty arthritis, patient could be having chronic gout and presenting in between with acute bouts of gouty arthritis. So every time a different set of joints is involved. Of course, predominantly the metatarsophalangeal joint is involved, but there are other joints that could be involved. And sometimes we see migratory polyarthritis, as we see in rheumatic fever. So the pattern of joint involvement has a lot of importance in clinching the diagnosis. While doing a physical examination, these days we do something called a joint count. When you're physically examining the patient, you need to look at how many joints are swollen and how many joints are tender. These are very easy to evaluate. You can very visible to the eye. So you count the number of swollen joints and you count the number of tender joints and you could mark them. And then you could use this information in a formula called the DAS28, which helps you to calculate the activity of the disease. So we can actually calculate whether the disease is very active, if it is in remission, or if it is partly active. So if the disease is active, we'll find higher values. So DAS28 is a widely used clinical tool, very freely available on the internet. There is a formula that you need to just fill in how many swollen joints and how many tender joints, and then you make a physician evaluation of how the pain is in a scale of 0 to 10, and the patient also gives you some feedback of how he or she feels on a scale of 0 to 10. You put these 4 values, and if you have ESR, then it makes it that much more useful. Or alternatively, you could be having CRP, and you can use that to get a value, and you can objectively determine how the disease, what the disease status is. So if it is in remission, then you can continue with the same treatment. If the disease is active or highly active, then you need to increase your medications, maybe make a little change in the treatment. There are other simple indices like common disease activity index, CDI, and simplified disease activity index, SDI. These don't need ESR or CRP, so many of our patients can't afford ESR or could not do a ESR and just walked into the clinic. So you could just do the simple calculation and know how the disease status of rheumatoid arthritis is. So this is particularly useful in treating rheumatoid arthritis and following patients. The BASDI is used in ankylosing spondylitis. So most of the information which you get clinically is good enough to make a diagnosis, to come to a conclusion, to plan your treatment, and to follow up the patient as well. So it's largely clinical and a lot of work can be done. But there are certain investigations which help us, which support us, and which augment this information from the investigations. See, acute phase reactants are very useful, like the ESR, CRP, the platelet count, the serum globulin values, and the reversal of the AG ratio. These would all indicate an acute phase reactant activity, the total leukocyte count, and the alkaline phosphatase. Besides these, imaging has its own contribution to diagnosis and follow-up of a case of acute polyarthritis. You get the typical erosions on X-rays of the hands or the feet in cases of rheumatoid arthritis. So erosions are very typically, they give away what is known as an aggressive disease. So a high ESR with a bad DAS28 count with erosions on the rheumatoid arthritis, we need to be careful. We need to be more aggressive with the treatment. There could be juxta-articular newborn formation as in psoriatic arthritis. We could see scooped out lesions in chronic gout. Sacroiliitis, of course, is very well known to everybody in spondyloarthritis. Of course, CPPD crystals, these are become much easier to diagnose now with using ultrasound than, of course, bone marrow edema, a very early sign of sacroiliitis, as we see on the MRI. So there are a few messages that I would like you to take with you. Uh, One is that the polyarthritis is a very common medical condition. It's a very, very common medical condition. And it's important to diagnose. And it's important to distinguish inflammatory from non-inflammatory joints, because inflammatory joints can take a very bad course and can lead to a very chronic and debilitating disease. The diagnosis is mainly clinical, so if we do take a good history and do a patient physical examination, we can clinch the diagnosis in most cases. And the timely diagnosis can actually alter the disease course and the prognosis for the patient. Thank you very much for your patience here.
Any question from the audience? It's 2 minutes time, sir. Thank you, sir. There is no question. We will discuss it later on. Thank you very much, sir.
Thank you, sir.
Now, our next speaker is Dr. G.K. Mitra from Ranchi, clinical approach to a patient with PUO. A person who is known as a teacher, as a physician, as an examiner to the whole of the Jharkhand. And for Japicon, he has introduced Japicon in Jharkhand. Thank you.
Thank you, respected chairpersons, for a kind introduction. And these are the 2 slides which have been prepared by my students with, oh my God, right. How to, excuse me, please. अच्छा इधर उल्टा हो गया था, उल्टा था इसलिए, right? And ये सबको anyway, thank you. So it was just उल्टा हो गया. Now this is a fever which we had just raised the issue in free paper presentation also. So this is a very common presentation and very common symptom. All the time the patient is coming to with fever is also there. And if you ask me, in the era of Superman, super specialties, the fever has been left to the physician. और बहुत बार बोलते हैं ना कि physician बुखार जो है, बुखार physician का बुखार छुड़ा देता है. So sometimes it becomes very difficult. if बुखार छूट गया तो छूट गया, नहीं छूटा तो आपका बुखार छुड़ा देगा. So just coming to this, and this is just a definition of fever, which we know that it is a state of elevated core temperature, which is frequently but not always part of the defensive response of multicellular organs. So it is a defense mechanism which by fever it is manifested. Now coming to the subject concerned, PUO, FUO or PUA, FUA, whatever you call. PUO or FUO refers to a persistent febrile illness. In free paper also the definition had come with no established etiology despite extensive evaluation and diagnostic testing. And this by Petersdorf and Bisson in 1961 defined PUO as an illness more than 3 weeks, first point, with a fever of more than 101 degree or equal to 38.3 degrees centigrade on 2 occasions and an uncertain diagnosis despite 1 week of inpatient evaluation. But later on in the definition, inpatient evaluation and immunocompromised states have been removed from the recent definition. And according to, PO is now defined by Durek and Street as follows: fever 38.3 degrees centigrade, duration of illness more than 3 weeks, no known immunocompromised state, diagnosis that remains uncertain even after a detailed history and physical examination. So history and physical exam, these 2 things are very important. Following mandatory investigations. So these are the list of mandatory investigations which one must go before saying that is it. So how to classify? The classification. One is a classic. Second is a nosocomial. That means either in the ICU patient or non-ICU patient when the patient is admitted. Then immunodeficiency related. When the diagnosis has not been done and patient is not on ART therapy. Travel related cases and unknown. Why the epidemiology and etiology, if we call, as we already know from the primary education type, this one can be infectious, either bacterial or fungal or parasitic, or inflammatory, non-infectious. In inflammatory, it can be non-infectious, systemic, rheumatic, and autoimmune diseases, auto-inflammatory syndrome. Long list is there of the list. Crohn's disease, AOSD, adult onset, this Still's disease, which we're talking in that case, then Papa syndrome, PFS syndrome, Dira, SAPHO, TRAPS, so many syndromes are there of this. Then neoplastic, hematological, either solid tumor or benign tumors. Miscellaneous, then thermoregulatory distress, either it can be central or peripheral. If we talk about the incidence of pyrexia of unknown origin, infective is 17 to 35%. And non-inflammatory infective disease, 24 to 36%. Neoplastic accounts for 10 to 20%, miscellaneous 3 to 15%. And undiagnosed may be up to 51%. So why the regions of pyrexia unknown origin is increasing, and we are coming more of the cases of the pyrexia unknown origin, fever lasting for 3 weeks or even more. First of all, aging multi-morbid population. This is increasing on site. And by 2040, the maximum old people will be in India. So we are also heading towards in that. So now the youth is more, and next is our, for the elderly patient or the senior citizen number will increase. Human immunodeficiency virus, increased organ transplantation cases are occurring. And this evolving diagnostic test, they are also responsible. Either you talk about the changing microbial resistant pattern. Due to too much use of antibiotic, this is a changing microbial resistant pattern. In our country, infection remains still the leading cause. So in our part, leading cause still is infection, and out of that 50% accounts by the TB. And in case of tuberculosis, this extrapulmonary tuberculosis is very common. So the diagnosis of extrapulmonary tuberculosis is very important in this case. SLE and Still's disease, most common NID, lymphoma, the most important neoplastic disease. How to approach a case of PO? First of all, step 1, the clinical approach. Clinical approach is very, very important. And the sign or symptom, this is fine, which is being elicited, that must be as taken as, and the approach should be started, and that should be called as a potentially diagnostic clue. And on that basis, one should proceed with that. So this concurrent symptom, immunosuppression, family history, travel history, thorough physical examination. This is very important, lab approach, inexpensive and individualized. So all the time, not by the list, one should investigate. It should be individualized. So tailored approach, as we call it, and we must consider the cost also. So should not go for unnecessary testing. Baker Rovers et al. Expanded the diagnostic algorithm like potentially diagnostic clue. Then step 3 is the test, more specific technique, either serology, ultrasound, CT, MRI, nuclear medicine test, nucleotide scanning such as gallium-67 or technetium or indium level leukocytes, endoscopy, PET and LP biopsy. How to approach a febrile patient again? The most important step is meticulous, detailed history. We do not spend time on the patient to take the history, and that is a very important part. All the time history, patient tells his diagnosis. As it is said that patient all the time tells his diagnosis, and one should be very careful in listening and asking to the patient. That part, this communication gap is increasing, and this portion we are all the time, this is a gap which is there in this case. And this meticulous distant history all the time should be taken from the patient, from the attendant of the patient, and this thing. So all the time, one should remember that manifestation of common diseases are commoner than common manifestation of uncommon ones. So this line is very important. And because stuff, this we saw about the Beaumont's, he tells that, he was used to tell, that if you are not able to diagnose a case within 3 minutes of the entry of the patient, you will miss the chance for diagnosis, the test, this thing. Then chronology of symptom, that also is important, which was the first, which symptom appeared. So chronology important in this case. Drug fever is not uncommon, and drug fever uncommon, therefore easily missed. So one should also take the drug history. If the patient is taking, drug fever should be also considered, and the surgical or dental procedure. Sometimes patients who known have rheumatic heart disease and develop infective endocarditis if not given prophylaxis, or some prosthesis like knee replacement or something. In that case also, the fever may persist in this case. Then occupational history include exposure to animals. This is very, this also should be considered. Then household pets. Is there household pets or not? Then ingestion of unpasteurized milk or cheese, sexual practice, IV drug abuse, alcohol intake, prior transfusion or immunization, drug allergy. And whenever the history taking is there, sore throat, this will give the clue, sinus pain or this, or the genital symptom that we can prove, abdominal symptom. Ask about abdominal symptom is there or not, gastroenteritis. Then joint symptom, about the joint symptom, one should ask about the patient is having this type of infection. And this drug history, drug which are, which is, and therefore easily missed. The culprits include allopurinol, nifedipine, clofibroid, captopril. These are the drug list which may cause drug fever. So one should stop the drug and also see for 24 hours whether the fever is responding or not. And recently, one thing is also there, post-COVID. Post-COVID fever has also become very common. They have seen 2-3 patients who had fever for no reason. Everything was fine. And they were having the post-COVID symptom as a fever, they say. Then family history, that also should be taken. These are just the basic, and one should not forget the basic basis is very important for the diagnosis. Then ethnic origin of the patient is important, from which tribe it is. The fever pattern, whether it is intermittent, remittent, or hectic fever, or sustained fever, relapsing fever, that also will help in the diagnosis of the disease. Like if it is intermittent fever, deep-seated infection may be there, malignancy, drug fever, remittent maybe in case of tuberculosis or viral infection, many bacterial this thing, and relapsing fever in the malaria or Borrelia, or this can occur in this case, persistent fever. Previously it was seen in case of Hodgkin's lymphoma, but now the brucellosis has been claimed for this fever. And that fever pattern cannot be considered diagnostic for a particular infection or disease, and the typical pattern is not usually seen because of, many times we don't see the typical pattern due to the use of antipyretics. Patient used to take antipyretic or steroid or antibiotic. So misuse of these three drugs all the time may not give the correct fever pattern. Then temperature, the pulse dissociation, relative bradycardia is there, then it may give some clue. Then fever pattern again, fever with extreme degree or non-fixed cause of extreme pyrexia. Even the heat stroke or non-infective like intracerebral hemorrhage. Physical examination, important points, repeated meticulous examination is very important on a regular basis. Better by different colleagues also, you may take the help of, many times the biased opinion is there, and in that case you can miss the important sign in the case. Temperature should be taken orally or rectally. Axillary temperature is notoriously unreliable all the time. Fever may sometimes be absent. If the patient is having fever, the fever may be absent. Seriously ill, newborn, in this case, elderly patient, uremic patient, significantly malnourished individual, receiving corticosteroid or continuous treatment with anti-inflammatory or antipyretic agent. In this case, the fever may be absent. Cautions while taking oral temperature, if the patient has taken the hot or cold drinks or smoking or hyperventilation. Then one point is also there, the factitious fever. This is defined as fever created by patient. So just it is created by the patient and they manipulate, either malingering are there. Thermometer and the temperature chart apparently to obtain medical care. Uncommon and typically present in young women who work in paramedical profession. The dipping of thermometer into the hot drink. The factitious disorder is usually medical but may relate to a psychiatric illness. Clues to the diagnosis of factitious fever. A patient who looks well. Then absence of temperature, related changes in the pulse rate. Temperature, if the record is 41 degrees centigrade. Absence of sweating during, may be there, normal ESR and CRP. So one should be careful in taking this history and observing these points. There may be a factitious fever which may be confusing. And the treatment, what will be the treatment of pyrexia unknown origin? We talk in that case. Then first of all, supportive care all the time. Antibiotic or anti-tubercular drug. If no response in 6 weeks, then another diagnosis to be considered. If it is given in this case, then one should consider colchicine is helpful, in especially if it is a post-COVID fever. NSAID for AOSD and a steroid. Anakinra is a highly effective in treating a variety of autoinflammatory syndrome this interleukin blockade monotherapy may provide better control. Then prognosis, if we talk about the pyrexia, and what is the prognosis now? In past few decades, pyrexia for known origin related mortality rate have decreased. So the mortality has decreased, and most fevers are caused by curable disease, and await diagnosis before considering treatment. So one should not start the treatment as, not be hastily should not be started the treatment. Before considering the treatment, one should try to find out what is the diagnosis there. And now the mortality rate is less than 10%, with most death being due to malignancy. So infection and malignancy must be ruled out. First of all, the treatment, in that case, the malignancy and infection must be ruled out. Then use of steroid decreases the chances of turning a diagnosis. May worsen if the infection and malignancy is there. So in case of lymphoma or leukemia also, the alone drug, one drug is used. That case, that may be facilitated this case. Right. This was a flow chart, very busy slide. I don't want to go with this case, but if the fever is there, you can approach like this in the case of flow chart. But everybody is very trained and very expert in treating fever. They don't bother. They start treatment as such. Any antibiotic, anything, and then fever used to subside if you're lucky, and sometimes it creates problem. But again, the two things are there: misuse of antipyretic, misuse of antibiotic, and misuse of corticosteroid. That should be very carefully done. And the antitubercle therapy, which we used to start, and you stop it after 2 weeks. That should not be done. If it is there, 6 weeks must be there before considering the other diagnosis. And all the time try to consider. In that case also, steroids should be avoided. So despite better understanding of the diseases, responsible and easier access to the diagnostic test, PUO remains a clinical challenge. So this is most of the time it is an enigma, and it is a clinical challenge. And as you see, all the supermen all the time, if the fever, the patient is having fever, you will have to deal, if you are a physician. So in that case, PUO remains. Newer technologies such as fluorodeoxyglucose PET is a promising diagnostic tool. However, a thorough history, this is a very important take-home message. A thorough history and physical examination is the most crucial steps in establishing a diagnosis and directing further investigation. So thank you very much. 2.42. So 3 minutes I have saved.
Thank you, sir. Any question from audience, please?
Fever is a
Hello.
very
Sorry.
simple case. Oh, sorry. All right.
Sir, I just want to know, in one of your slides you have shown role of steroid.
Pardon?
Steroid.
Yeah.
I just want to know what are the indications of using steroid in case of PUO, number one. Which steroid would you prefer and for how many days?
So, very practical question in that case. First of all, steroids should not be misused, and steroid alone should not be used, right? And antibiotic and steroid all the time, as it was said in this case, many times you combine antibiotic with steroid. So that is also not a good practice. Steroid usually in the case of non-inflammatory, this disease, in that case, or the what we call the immunomodulators that you need, in that case, this is very effective. As I was telling, the post-COVID fever. In the post-COVID fever, the colchicine was tried, but many times the colchicine was not a success in that case. And steroid all the time was effective. And depending on the dose, if it is a case of this inflammatory disease in this case, then 60 milligram, 1 milligram per kg body weight should be the ideal dose. If you are using for, say, just with the antibiotic and this thing, in this case, start with the 30 milligram. If you are using 30 milligram, after the when the fever has subsided, you may continue it for, say, another week, and you can taper. But if you are giving for a short term, just for a few days, tapering is not needed in that case. But if it is a case of SLE or ASD or this whole the lift was there, in that case, at least many times you have to give even for the 6 months. So in that case, the maintenance dose has to be sought out. So that is important. So.
Dr. Mitra, thank you for a wonderful presentation. In usual workup of PUO, one of the most important diagnostic tools is abdominal ultrasound. And when we do this ultrasound, we see mesenteric lymph nodes. And the conundrum is that these nodes are not amenable easily for FNAC. So I don't know what to do with these patients. Start antituberculous. Majority of the patients would respond. If one or two doesn't respond because he or she had malignancy, then later you are pulled in the consumer court. Today, at this point of time, do we have any clinical suggestion as to how to solve this conundrum? Ultrasound, mesenteric lymph nodes, not accessible to FNAC, what to do?
So treatment portion, practical portion, medical legal portion. These are the three different aspects which we have to face. And nowadays you see, even the alternative medicine, they are getting the same pay. So that is also there. So the alternative medicine, they are always safe. They are never pulled to the consumer court. They are never pulled. But whenever you are practicing the English drugs, then all the time there is a chance. And as I was telling in the case of, in our country, the most important cause of PUO is the infection. And out of that, 70%, 51% is infection. And out of that lot, 51%, 70% is tuberculosis. And that 70% is EPTB, extra pulmonary tuberculosis. And that has to be decided by the physician, whether to give him the treatment of EPTB or not. The best thing is to leave the EPTB, if the EPTB is giving, and when you have a doubt, suppose it is a case of abdominal tuberculosis, you use steroid with the treatment. But if it is EPTB and there is a doubt, don't use steroid. Without steroid you give, and wait for 6 weeks. If the patient is not responding, that means either lymphoma, some malignancy may be there, and then he should be subjected to further evaluation, CT, MRI, or the PET scanning, or all these things. Then only the problem will be solved. I think 6 weeks trial, that will be more wonderful. But if you think, if you see, be careful, try to save yourself first. If you see the patient has got some high value, then better you subject him to for the investigation and then start. Let him wait. Let him wait, let him for the biopsy, or let the disease spread. That is the only answer. It's the practical aspect, not from this stage I am saying, but I am saying from that stage, from the practical aspect of view.
I think some centers are doing CT-guided FNAC in these cases. CT-guided FNAC.
That is the final and the surest sign of any disease. If you are having the help of pathologist, and the biopsy report suggests that there is a glomerular change and this is a case of tuberculosis, nothing like that. If you can show AFB in any sort of thing, the yield is less. You may not get the AFB this right. But if you get AFB, that is a surest sign, and ask moon ke usko antituberculous region. Even if the patient is not responding within 6 weeks, you continue that drug.
I think another very important cause that is often missed of PUO is hyperthyroidism. And patients with hyperthyroidism, they present with PU, unless you do the thyroid function test, you miss it.
Yes, maybe. And
first of all, Dr. J.K. Mitra, excellent presentation about this PUO. And about this size of the lymph node is also important. Under the ultrasound, if you get the size more than 2 centimeter, chances that it could be tuberculosis, and yes, of course, that CT-guided this diagnosis will be there. Other things also. Sometimes one of the patient came to me, fever for 6 weeks. She was pregnant, and there was just 1 Fahrenheit elevation. That was physiological fever. And many physicians treated him with these antibiotics and other things. As you know, that it's dangerous to put antibiotics in the pregnancy. So even the physiological fever, 1 degree elevation, that's usual in the pregnancy, they are treated as PU. So
yeah. Many
also.
times the misuse of antibiotic, and that has resulted in this superbug. Superbug is nothing but it is a man-made thing. So man-made bacteria, this is the type of that. And one thing is more, suppose if ultrasonologists, they see that there is matting of the gland, they say, then this is a surest sign. Then you can go for the distance. But again, they all the time write PCC. PCC means please correlate clinically. Yeah. So nobody is responsible for you. So they will also withdraw the hand. So in that case, the medical legal point, we should be very careful.
Thank you, sir.
So
and secondly,
thank you, sir. Now we are running short of time. Please,
one
sir.
thing is there. Sir, just a minute. if it is a case of tuberculosis and you are giving, you must all the time also consider about the incidence of MRD. So multi-resistant tuberculosis is also emerging. So sorry, sir. Thank you.
Thank you, sir. Because we are having one more speaker. He is a renowned practitioner of Ranchi and president of clinical cardiology. Dr. Bineet Jagnani, young man, very dynamic. So he will talk on clinical approach to a patient with acute breathlessness. All these topics you might be noticing that are the very day-to-day events, and we come across always. So Dr. Bineet Jagnani, please.
Thank you, sir. Respected chairpersons, Dr. Virmani, sir. Thank you, Japicon, for giving me this opportunity to talk here on acute breathlessness. Well, we all know that acute breathlessness is defined as an uncomfortable awareness of breathing, which could be orthopnea, PND, trepopnea, platypnea. And in our practice, in various specialties, we see somewhere 10 to 50% of patients suffering from dyspnea, which is due to the inappropriate balance of oxygen consumption and carbon dioxide elimination, and because of the inappropriate partial pressure of oxygen, CO2, pH of blood and CSF, which leads to the altered rate and pattern of ventilation due to the neural receptors, leads to such condition. In pulmonary edema, the fluid activates the neural fibers, whereas in inhaled substances, similar things occur which lead to dyspnea. In anxiety, there is hyperventilation, which can cause reduction in CO2, but that does not alleviate dyspnea. There are various causes of dyspnea, in which the respiratory causes could be infective, asthmatic, pleural effusion, embolism, pulmonary hypertension, occupational, restrictive or interstitial lung disease. Even metastasis and GERD can also lead to dyspnea. Sometimes physiological causes like humidity, exercise, temperature, intra-abdominal obesity, ascites can also lead to dyspnea. The cardiac causes would include left ventricular failure with reserved and preserved ejection fraction with arrhythmias and CADs, with valvular involvement, tamponade and diastolic dysfunction, which we invariably miss out. Also, the psychogenic cause, thyroid disorder, should not be missed out when we talk of dyspnea. While diagnosis, it's important to get the history, as Mitra sir was right now saying, that history is very important when we talk of any diagnosis. So onset, duration, pattern, the severity, any diurnal variation, any aggravating relieving factors, any medicines which triggers, the pattern of dyspnea, the correlating conditions will lead to appropriate diagnosis of dyspnea. If we talk of acute onset, sudden onset, it could occur in pulmonary thromboembolism, acute coronary syndrome, spontaneous pneumothorax, ARDS, or foreign body aspiration. If it is little slow progressing over hours and days, it could be COPD, pleural effusion, infective cause, congestive heart failure, like that. So if we talk of causes of dyspnea, and if it is occurring on exertion, we should think of cardiac and pulmonary causes. If it has rest, probably the severity is high. Sometimes metabolic disorders can lead to dyspnea. Orthopnea is more so common in congestive heart failure. Beta blockers are also known to cause dyspnea. Smoking leads to asthmatic cause, and wheeze leads to asthma. In CAD, dyspnea should be considered as angina equivalent, hypertension leading to congestive heart failure, and left ventricular hypertrophy also leads to dyspnea. In anxiety, there is hyperventilation, which can cause lightheadedness and tingling. Trauma also leads to limited breathing and hence dyspnea. Exposure to the dust, asbestos, etc. leads to interstitial lung disease. Measurement of dyspnea is important because it affects the quality of life as well as daily activity is affected. Whether the breathing is sufficient or insufficient, is the person satisfied, dissatisfied with his breathing pattern? There are various scales like rating of perceived exertion, the Borg scale, the MRC scale, which helps us to find out the severity of dyspnea. Likert scale is important, which compares the dyspnea from the previous week. So these are the various scales which help us to diagnose the severity of dyspnea. Physical examination is equally important, as we see nasal polyp with nasal obstruction which leads to dyspnea, Jugular venous distension can be seen in congestive heart failure. Peripheral vascular disease and coronary heart disease will lead to bruit. The AP chest diameter increases in emphysema. RALs are more so common in pulmonary edema. Tachycardia occurs in hyperthyroidism, anemia, hypoxia. S3 gallop will be seen in congestive heart failure. Murmurs are more so common in valvular involvement. Cyanosis and clubbing are important in chronic infections. If the patient is presenting with cough, probably we should think of infection or asthma. If it is pleuritic chest pain, it could be also pneumothorax. Orthopnea is common in acute heart failure, whereas fever is common in infection and malignancy and tuberculosis. Hemoptysis is more so common in malignancy. Pulmonary edema is more so common in acute and chronic heart failure or ARDS. Tachypnea is important in aspirin toxicity and pulmonary embolism. So this is a pictorial representation of how to approach a patient with dyspnea, whether we have unilateral, bilateral, whether absent sounds. All this will help us to diagnose the cause of dyspnea. Now, this is centrally controlled. So if the control is at the respiratory rate level, we should think more of metabolic acidosis and anxiety because there will be air hunger. In ventilatory pump involvement, it's more of neuromuscular function where the work of breathing increases. If the gas exchange is altered between oxygen and CO2 at the membrane level, the respiratory drive is increased, which is more so common in hemothorax, emphysema, etc. This is a algorithm to approach of dyspnea. Sometimes patients present with respiratory distress where the respiratory rate may be more than 25 with SpO2 of less than 93, and patient may present with respiratory arrest. There could be gasping cyanosis where the respiratory effort is minimal. Upper airway obstruction present with stridor, and there is use of accessory muscles and tachypnea, anxiety when there is severe respiratory distress, and patient may present with hypotension. So the differential diagnosis of acute dyspnea could be cardiac, pulmonary, psychogenic, obstructive, endocrinal, central, hepatic, renal, or pediatric causes. We need to have some diagnostic tests like maybe the blood counts which help us to diagnose the anemia or the infection. The comorbid conditions with blood glucose levels, hypothyroidism should be ruled out. Spirometry helps us to understand the pulmonary cause. The chest X-ray ultrasonography helps in pulmonary cause, whereas ECG helps, ECG, pro-BNP, etc. helps us to diagnose the cardiac cause. In advanced cases, we may require some ABGs, CT scan, or perfusion scan. In spirometry, obstructive or restrictive causes can be differentiated, where obstructive could be COPD and asthma, and restrictive could be more of the extrapulmonary causes. Pulse oximetry, which determines the oxygen saturation but may not correlate every time with partial pressure of oxygen. Therefore, that should not be considered as the only tool. It could be just a guiding tool. Cardiopulmonary functioning test is helpful in measuring the lung volumes, and if it is differentiating obstructive restrictive good, otherwise we may require diffusing capacity of carbon monoxide, the DLCO tests. Treadmill tests are more so important in cardiac conditions and quite helpful in ruling out angina. Echocardiography is more so helpful in valvular involvement along with other cardiac causes. Muga scan is helpful when echo is not sufficient. Radionuclide ventrography identifies ejection fraction more easily. When TMT is not sufficient, then we need to go a comprehensive cardiopulmonary exercise test, which will talk about the cardiac function as well as pulmonary gas exchange, ventilation, and physical fitness. Also, it will differentiate with obesity, anxiety, etc. USG is sometimes helpful in acute causes of acute dyspnea, where the lab tests are still awaited. Therefore, history clinical examination is important in finding the diagnosis. Coming to the treatment, in acute dyspnea, we may start with oxygen or heliox, where heliox is lighter and therefore easily helps in alleviating acute dyspnea. Inhaled medications are very helpful. The steroids and beta agonists in pulmonary causes. This is probably the symptomatic treatment. Sometimes anti-allergic are helpful in allergic reasons. Antibiotics will be useful in infective causes, and cardiac management will be required in heart failure or CAD. Anxiety can be relieved with SSRIs and benzodiazepines. Along with the medical management, we need to have pulmonary rehabilitation, the non-pharmacological management. Alternative medicine, we do not have sufficient data, so we should not rely on much because that can be detrimental sometimes. Nasal high flow cannula is sometimes helpful, is quite helpful in initial stages. If that is not sufficient, we may need to go with BiPAP and CPAP. Even if that is not sufficient, we need to go for mechanical ventilation and sometimes even ECMO. Heliox, as we saw, that because of the lesser density of heliox than oxygen, it improves the exercise capacity and therefore relieves dyspnea quite fast. Non-pharmacological management in long-term management of dyspnea is quite important in terms of reassurance, the breathing pattern, the complementary therapy, the psychological support. Smoking must be avoided and pollutants must be avoided, which are the triggering factors for dyspnea in many of the patients. When we talk of pulmonary rehabilitation, the posture, the breathing techniques, the anxiety relaxation, all these are important, and regular exercise plays an important role in pulmonary rehabilitation. Shallow and rapid breathing is very ineffective. Therefore, we should encourage slow, regular and deep breathing. The diaphragmatic breathing, or in acute situation, even pursed lip breathing is quite helpful, where we promote nasal inspiration and exhalation through the mouth. So this is how we do breathlessness management at home in self-care or the rehabilitation thing, where pursed lip breathing, the support with table or tripod stance are involved. Sometimes support with back or arm or diaphragmatic breathing is quite helpful in dyspnea management. With that, I would like to thank you all for your patient listening.
Thank you, sir, for the wonderful talk. Any question from the audience, please?
Dr. Vineet,
Sir.
For the benefit of our PG students, how will you differentiate cardiac from pulmonary dyspnea?
Sir, right now, just like Mitra sir was saying, let's start with history. That is one. Detailed history is quite helpful. If there is fever, we should think more of pulmonary cause, whereas cardiac causes will have less chances of fever. In pulmonary, the pulmonary and cardiac can also be differentiated on chest X-ray, echocardiography and ECG, which are the basic investigations and easily available. On auscultations, if we see more of a rhonchi and coarse rales, probably we are, in most of the cases, we are dealing with pulmonary, whereas if they are fine rales, probably we are dealing with a cardiac cause. Of course, the blood pressure, that is also quite important, which will differentiate. If there is any constricting chest pain, probably we think of cardiac pain. Whereas if there is any tightness, probably it is a pulmonary cause. So this, it should be a composite approach to diagnose whether it is pulmonary or cardiac dyspnea. Invariably, we see that all dyspneic patients are being given inhalations, steroids and all, which may not be sufficient. Sometimes simple uncontrolled blood pressure leads to dyspnea. So management of simple hypertension with maybe diuretics will be sufficient to differentiate, yes, this was a cardiac cause.
No, to add to Dr. Virmani's question, we just want, based on the history, how can we differentiate whether it is the cause of breathlessness could be cardiac or pulmonary, based on the history?
Sir, I guess if it is cough associated, we should probably think of pulmonary cause. If it is exertional, we should think of cardiac cause. One simple one-liner can be this, sir.
I think besides history and all that, in today's, the way we practice medicine, just doing a simple pro-anti-BNP will give you the answer.
Yes, I agree, sir.
Am I right, Dr. Mandar?
I agree, sir. Absolutely. I agree, sir.
Any comments?
No, very rightly so, sir. So, in fact, I was going to come up with this comment that whenever you are in doubt, there is a lot of, however, theoretically you can say that it can be differentiated from history. Sometimes in clinical practice, we do find that it is very difficult to differentiate. So, BNP is a simple bedside tool nowadays, so it is a point of care device which is available and which can very easily differentiate cardiac from respiratory causes.
Thank you, sir. Okay. Thank you so much.
Thank you. Now we are concluding the session. Thank you all.
Well, friends, you would agree that all the speakers deserve a very loud round of applause for an excellent talk. I would like to thank sincerely to all the chairpersons and all the speakers. We are going to have the memento presentation on the dais. May I request the chairpersons to please hand over the memento to our speakers. Our first speaker, Dr. VSB Prasad, sir. Memento to be handed over to Dr. VSB Prasad, sir, by Dr. DK Singh. Center में आ जाइए. May I request Dr. JK Mitra, sir, to please come on the dais. Dr. Sarkar, sir, to please give present memento to our dear Dr. J.K. Mitra, sir. May I request Dr. Jagnani to please come on the dais. I will also request the speakers to please stay on the dais. Madam, to present to Dr. Jagnani. I think it is in the process. May I request the speakers, Dr. VSB Prasad, to hand over the memento to our chairperson, Dr. DK Singh, sir. Memento of Dr. DK Singh to be presented by Dr. VSB Prasad, sir. Memento of Dr. Sarkar to be presented by Dr. J.K. Mitra, sir. And memento of Madam to be presented by Dr. Jagnani, sir. Please come on the front. Come in the front. So we have got memento for Dr. Vineet Jagnani also, and I would request Madam to please present the memento to our speaker. Hey, can we have a clap, yaar? Please. क्या कर रहे हो? अब भी हाइट ही हुआ है. There show us some energy. Thank you so much.
The next session is the debate. And since the theme of our conference was from controversies to consensus, now I will just tell you the rules of the debate. Both the speakers are given a total of 15 minutes to talk. A warning bell will be given at 13 minutes, but they have total 15 minutes. After that, there is 2 minutes of rebuttal by both the speakers, followed by the moderator's final comments in 1 to 2 minutes. So these are the rules of the debate.
Okay, so to move ahead, may I request the chairperson or the moderator for this debate number 1, Dr. Sanjay Srivastava, to please come on the dais. The timekeeper, please note the bell. The bell will go at 13 minutes. Warning bell. Dr. Sanjay from Tata Motors Hospital. We have got 2 speakers on this debate, Dr. Ajay Chabra and Dr. Sudhir Kumar from Bokaro. Welcome Dr. Ajay Chabra and Sudhir Kumar to Jamshedpur, academic city of Jharkhand. May I request I would request both the speakers to please come on the dais.
Dr.
Ajay
Sudhir and
Chabra from
Dr.
Ranchi
Ajay.
and Dr. Sudhir Kumar from Bokaro. Please. The topic of debate is, should triglyceridemia be treated with drugs? Dr. Chabra is speaking in favor and Dr. Sudhir Kumar is speaking against. I would request our moderator for this evening, Dr. Sanjay, to please proceed with the formalities. Dr. Sanjay, please.
Thank you, Dr. Arya. Good evening, everybody. And thank you, Virvani sir, for choosing such a nice topic of debate, which is, very common problem, triglyceride, whether to treat or not. Nowadays, patients are coming with a bunch of reports. Most of patients, nobody has normal triglyceride, that is less than 150. So most of have more than 200, 250, like that. And most of us are very much interested in writing anti-hyperlipidemic drug in those cases. So what the current guideline is, and what are we have got two renowned, debaters, Dr. Sudhir and Dr. Ajay Chabra. Both are from Jharkhand only. So Dr. Ajay Chabra will be speaking in favor of drug therapy in case of hypertriglyceridemia, and Dr. Sudhir will be talking against it. So I request Dr. Ajay to proceed further. Thank you.
Thank you, Chairperson. Thank you, Japicon team. Thank you, Dr. Virmani, sir. And thanks for inviting us. And we'd like to congratulate you on the outset for this great academic extravaganza. Jamshedpur has always been a benchmark in terms of organizing conferences. I remember the first RSSDI annual conference we had in Jamshedpur, and sir had invited all of us. So thank you once again, and a big congratulations to all of you. For today's topic, I need the slides, please. देख लें? Thank you. So before the slides come into the picture, there has been a big debate since last many years whether we should treat high triglyceride levels in our clinical practice or not. But someone who practices diabetes like me, we usually find most of our type 2 diabetic individuals, they come with a typical type 2 or diabetes dyslipidemia-like picture, where they have high triglyceride, low HDL, and sometimes normal or high LDL. So we are always in a fix whether we should treat these patients or not. So let us see, with the help of some of the slides, some of the data, whether we should go ahead and treat these patients or not. ये वाला नहीं काम कर रहा, किधर पॉइंट करना बताओ, इससे कर लो, ये हो जाए. There is some technical glitch. ये वाला. Thanks. That's my disclosure. I have no relevant financial relationship to disclose. Hypertriglyceridemia pharmacological intervention. To introduce hypertriglyceridemia as a condition in which triglyceride levels are elevated. It is often caused or exacerbated by uncontrolled type 2 diabetes, obesity, and sedentary habits. In epidemiological and interventional studies, hypertriglyceridemia is a risk factor for coronary artery disease. Hyperlipidemia is present in all hyperlipoproteinemias. Now, just to define hypertriglyceridemia, I'll be showing another slide. These are the metabolic disorders which are associated with plasma triglyceride elevations. This is called excess adipose tissue, inadequate insulin action, insulin resistance, type 2, type 1 diabetes, nephrosis, renal failure, hypothyroidism, and gout. Chemical substances that may elevate triglycerides. One is alcohol, second is estrogen, oral, whether the patient is taking as a contraceptive pill or on hormonal replacement therapies, retinoic acid derivatives when you are treating acne in females, basically, thiazide diuretics when they are given high dose for a long period of time, and beta blockers. Now, this is a typical picture of triglyceride-rich lipoprotein. On the left side of your screen is chylomicrons, which has 85 to 90% of triglyceride. On the middle is VLDL, and on the side is IDL. The size of chylomicron is very big. VLDL and IDL are of the smaller size. So just to say, triglyceride content alters the LDL particle size, and hence LDL particle numbers are changed and they become more atherogenic. If you see the size of the particles, the chylomicrons and large VLDL are unable to enter the arterial intima, whereas small VLDL and IDL are able to penetrate the arterial intima and have been shown to be associated with presence, severity, and progression of the plaque. This is the typical diabetic dyslipidemia I was talking about. Now let us see whether triglyceride level as an independent risk factor of CHD or not. We have so many studies: ProCam, Copenhagen Male Study, Lipid Research Clinical Follow-up Study, Helsinki Calls, and Framingham Heart Study. Most of the studies, they suggest that high triglyceride levels predict coronary events even when associated with high LDL, low LDL, or at times with normal LDL. Hypertriglyceridemia, significant CV risk. This is meta-analysis of 29 studies, and it clearly shows that patients with highest tertile of serum triglyceride had 72% higher risk of CVD than those in the lowest tertile. Now this is a very simple diagram to explain that CHD associations with TG and HDL. If you see the right side, the big box, the total CAD events is 128 when you have high triglyceride and low HDL. So on the right side, the high triglyceride and low HDL, you have 128 events. Elevated triglyceride is a synergistic risk factor. Irrespective of your LDL, if your triglyceride continuously goes up, the chances of cardiovascular dysfunction goes up. This is a relationship with LDL and triglyceride concentration. You can see on the right, the yellow bar, it goes exponentially high, 255 cases when the triglyceride is very high, even with the normal LDL levels. This is again a very important slide. Care and lipid study, 13,000 subjects were involved. And in this study, they showed that with the help of statins, you can very well reduce the LDL and control the cardiovascular risks. But with elevation of triglyceride, with the help of statins, you will not be able to prevent the cardiovascular dysfunctions or coronary artery disease. And this graph was plotted with the help of that study, the care and the lipid study, where more than 13,000 subjects were involved. Now, risk of CHD with increasing triglyceride. In a recent meta-analysis of several observational studies, the simple measurement of total plasma triglyceride in men has been found to predict an increase in vascular event by 33% with increase in 100 milligram per deciliter of triglyceride, and in women by 100% with increase in 100 milligram per deciliter of triglyceride. High triglyceride levels increases a small dense LDL fraction which are more atherogenic than large buoyant LDL. So at fasting triglyceride of more than 250, 85% of the population has predominant small dense LDL which are very dangerous and which are very atherogenic. Does lowering LDL reduces CV events? Yes, we have the answer. Yes, it does. In CARD study, we have seen 10 milligram of atorvastatin. It just helps to reduce the cardiovascular dysfunction by 37%. But again, see this slide. Effects of evolocumab in patients with type 2 diabetes, 11,000 patients in this 4-year trial. And we see that after optimum therapy with statin, around 14.4% of the patients, diabetic patients, had CV events, despite having normal LDL of 30. Thus, we need to look into other lipoproteins in view of high prevalence of atherogenic dyslipidemia, and they are triglycerides and non-HDL. So we have to make sure that we treat them. Is high TG a CV risk? Well, this is Lipid Association of India expert consensus statement on management of dyslipidemia in Indians, and it shows the normal values. Less than 150 is normal, 150 to 199 is high, moderately high is 249, and very high is more than 500. High triglyceride levels contribute to high residual risk after statin therapy. So if you have treated your patients very well with statin and still the patients are having cardiovascular dysfunctions, please blame this triglyceride and do treat them. This is a very important original investigation by Gregory Schwartz, and it was published in the Journal of American College of Cardiology. And it clearly stated that fasting triglycerides, they predict recurrent ischemic events in patients with acute coronary syndrome treated with statins. The patients are already on statins. And there are two studies. One is outcome study, other is a miracle study. And in both are randomized double-blind study with more than 20,000 patients. And they clearly state that there is significant decrease in CV events in those with triglyceride less than 80 compared to those with more than 175 or more than 195. Coming to the next, will treating a high triglyceride reduce CV events? Well, we have a meta-analysis of 5 landmark studies, Alcor, Field, BIP, HHS, and WAHID. And we see that 35% relative risk reduction with triglyceride lowering therapy in patients with baseline triglyceride of more than 204 and HDL less than 34. So we have a legacy effect of fibrate add-on therapy, similar to the legacy effect of management of high blood sugar. If you manage a patient's high blood sugar very well, very aggressively in the early part of his disease, you give him a very good legacy effect and you prevent the various micro and macrovascular complications in future. Similarly, we have a legacy effect of fibrate add-on therapy in diabetic patients with dyslipidemia. Fibrate treatment during initial trial period was associated with a legacy benefit of improved survival over a post-trial follow-up. These findings support re-evaluation of fibrates as an add-on strategy to statins in order to reduce cardiovascular risk in diabetic patients with dyslipidemia. This is a fibrate trial. If you have normal LDL levels and still the patients are at risk of cardiovascular disease, these are the 4 important trials: HHS, BIP, WAHID, and DIAS. DIAS was particularly for diabetic patients. It's called Diabetic Atherosclerotic Intervention Study. And in all these 4 trials, except HHS, where we used gemfibrozil and we had non-cardiac mortality as well, all these 4 trials, they showed that we reduce the CHD, fatal and non-fatal both, by around 22 to 33% if we treat the patients with fibrate or other agents. This is comparison of Alcor subgroup results with those from prior fibrate studies. Now, expecting evidence to treat TGL, we have 2 important trials. One is Prominent, other is Evaporate trial. Prominent is one very important trial, and it has got 10,000 participants from 24 countries divided into 2 groups. One group is receiving placebo, other is on pemafibrate 0.2 milligram BD. And we will have the results after 5 years, and this will give a conclusive evidence whether we should aggressively treat triglyceride from the very beginning of the disease. This is Lipid Association of India Lipid Profile Assessment for Indian population, the first and the second visit, how you should just check the patient's fasting and the non-fasting lipid profiles. This is practical algorithm for screening and management of hypertriglyceridemia. These are Lipid Association of India recommendations, and they clearly state that in all the stages of lipid management, you should aggressively treat triglyceride levels, especially if it is more than 500. You should aggressively treat them with drugs. Just lifestyle intervention is not good enough. We need drugs to treat them. If you very well have a bullet, shoot the enemy. Please do not wait for the enemy. We have made some historical blunders in the past. Do not do that. Do not do that now. If you have a bullet, shoot the enemy. These are the recommendations from European Society of Cardiology, which clearly states that drug treatment should be considered in high-risk patients with triglyceride of more than 200. This is class 2A recommendation level B. And it clearly states in high-risk patients with triglyceride of more than 200, despite statin treatment, fenofibrate may be considered in combination with statins. Just to conclude, ASCVD is common in Indian patients with or without type 2 diabetes. Not only morbidity, but also CV mortality is on the rise. Diabetic dyslipidemia is common in patients with diabetes. Priority is to reduce LDL with statins plus etimide or PCSK9 or fenofibrate. Attention needs to be paid to reduce TG and non-HDL cholesterol. Fibrates may play a role in reducing TG with possible benefits in reducing CV events. ICP 4 gram per day has shown promising results. These are the drugs which we are using right now, and we should treat high triglycerides because that's going to give benefit to your patients. Thank you so much. I finished before time, I guess. Yeah.
Thank you,
Thanks
Dr.
a lot. Thank you so much.
Thank you. So now it's time for Dr. Sudhi to defend.
So, at the outset, I would like to thank Dr. Virmani sir and the whole team for inviting me on this occasion. So, most of my task of physiology has been done by my friend Ajay. Now, I will go straight to the treatment part. So, I have nothing to disclose here. So, treating hypertriglyceridemia with drugs, I am breaking the myth. So, this is the intro which already has been taken by Dr. Ajay. HDG is a common lipid disorder which is characterized by increased level of plasma triglycerides, and it develops from primary genetic disorders or secondary causes, namely all those metabolic syndrome, obesity, drugs, and type 2 diabetes. So the consequences are known: atherosclerosis, pancreatitis, prematurely CAD, lipidemia retinalis, and other things. The classification is very confusing to most of the people, but we stick to AHA and ACC cardiology, this classification, which states very high TG value as more than or equal to 500. These are the risk factors. Most of the risk factors are metabolic syndrome and waist circumference increased, HDL reduced, and elevated TG levels, glucose levels, and blood pressure. There is causes such as insulin resistance, and diabetes is of course there. Secondary HTG is due to excessive alcohol intake, medicine use, endocrine diseases, renal disease, liver disease, pregnancy, and autoimmune disorders. So interventions to treat HTG. Management, both US and European guidelines highlight the management of lifestyle factors such as weight loss, alcohol abstinence, and increased exercise as the most important principle for management of HTG. And first line general measures should be addressing modifiable causes, non-pharmacologic measures, and assess and treat LDL cholesterol. So we have two targets in the management, in which we use to address HTG AP and ASCVD. And there is only lifestyle which is used to treat HTG level. Only medicines are used when HTG levels are not come down after lifestyle management process. So these are the interventions: lifestyle modification, which can reduce TG up to 70%. Weight loss can also reduce TG up to 70%. Blood glucose control also up to 70%. And administration of omega-3 fatty acids, although it is considered as supplement, it can reduce up to 50%, and fibrates up to 30 to 50%. So this is the intervention which is most remarkable in lowering TG levels. So lifestyle modification lowering up to 70% is there, in which alcohol abstinence and increasing physical activity is the most important. Weight loss 70%, I already told, and blood glucose control up to 70%. Omega-3 fatty acids lowering up to 30 to 50%. Administration of MCFA, it has a role, but it is variable. And of course, administration of fibrates, it has, as a monotherapy or in combination with non-statins, minor positive effect on cardiovascular endpoints. And in combination with statins, no positive effect in endpoint studies, and lowering of TG is 30 to 50% only. Administration of PCSK9 inhibitors, lowering up to 10 to 20%, and bile acid sequestrants can increase TG levels in patients. other treatment options. So in this, in individuals with ASCVD or other cardiovascular risk factors, on an statin controlled with controlled LDL but elevated TG, there is ICE which can reduce cardiovascular risk. It is level A. And in other combination therapies, usually statin plus fibrate combination therapy has not been shown to improve atherosclerosis CVD outcome and generally not recommended. Level A, statin plus niacin combination therapy is also not recommended and not shown to provide additional cardiovascular benefit. So these are also level A, not recommended. This is expert consensus decision pathway and step-by-step approach in which we consider lifestyle modification, secondary factors assessment, and in treatment we used to continue or intensify lifestyle modifications and surveillance. As the ASCVD risk increases, we intensify the lifestyle modifications and use of other modalities. So optimal lifestyle modifications, carbohydrate restriction, fat changes. This meta-analysis of 60 control trials shows a 1% calorie decrease in carbohydrate replaced with an ICE. Isocaloric increase in any type of fat reduces fasting TG by 1% to 2%. Weight loss most effective to lower TG levels. A 20% decrease in TG level is anticipated following 5 to 10% reduction in body weight. Exercise is very important. Diet, change in dietary macronutrient composition can contribute to weight loss and reduction in TG levels. The food higher consumption in MUFA, PUFA and dietary fibers also help in reduction of TG levels by 20 to 30% if we incorporate 4 gram of marine derived PUFA. So the NCEP final report 2002, there has been several RCTs and they show superiority of carbohydrate controlling diet over low fat dieting in management of TG levels. There is positive impact of carbohydrate controlled dieting in lowering TG levels in high risk patients and is often underestimated by physicians and not emphasized in practice. So medications, when should medications be prescribed? It is not indicated, medication is not indicated for primary prevention and there is no evidence of use of statins in combination with fibrates or niacin to reduce CVD. Systematic reviews do not support the use of omega-3 fatty acids for a primary prevention of CVD, and omega-3 fatty acids or niacin may be considered to lower pancreatitis risk in those with TG level of 500 or higher. So these are the trials: AIM high trial, Alcor trial, Look Ahead trial and Predimed trial. All these studies suggest lifestyle management including diet and exercise can be highly effective in managing STG and may be preferable to drug therapy. So these are the meta-analysis. There are 61 trials, 20 studies, all those show effect of use of lifestyle modifications and intensive lifestyle therapy to reduce TG levels. So these are the trials, and this is adapted from ESC ES 2016 guidelines. Lifestyle intervention magnitude of effect is very much and level of evidence is A. If we reduce excessive body weight, reduce alcohol intake, increase habitual physical activity, reduce total amount of dietary carbohydrate and N3 poly and PUFA, and reduce intake of mono and disaccharides is B also. Replace saturated fat with mono or polyunsaturated fat is also level of evidence B. So pharmacological interventions, side effects. There are so many side effects with even niacin and omega-3 fatty acids. Although these are considered supplements, there is GI side effects such as diarrhea, nausea, etc. And treatment with fibrates, there is these are used as adjunct to dietary modifications in management of TG. So treatment of fibrates, there are so many complications. And fibric acid derivatives, actually these are, there are mixed effects on LDLC. And fibrates, there are so many complications, CV complications, associated arrhythmias, MI, cardiomyopathy, thrombosis, pancreatic complication, pancreatitis, pancreatic cancer, and renal complication, AKI, nephrotic syndrome, interstitial nephritis is there, and respiratory complications are there, cancers are there, pancreatic, liver, and breast cancer, and non-pharmacological STG. These are the cornerstone of initial management of STG is lifestyle modification and combination of weight loss through caloric restriction, alteration in macronutrient composition, and increased energy expenditure reduces TG level by approximately 70%. So body weight reduction and all those dietary changes can reduce TG up to 40 to 50%. Supplements, IC, niacin, phytosterols, and polycosanol, and all these omega-3 fatty acids, rye, beta-glucans are there, which can effectively reduce TG levels. These are the studies related to all these supplements, and major RCTs are also there. So in moderate TGs, diet and this diet and alcohol use should be modified, and limiting alcohol consumption should be emphasized. In moderate to severe, also same. In severe TG, dietary fat should be less than 10 to 15%, and alcohol should be avoided. So in summary, approximately 15 to 20% of patients visiting medical practice are diagnosed with STG are incidental. Severity of STG varies widely, and TG levels show intra-individual fluctuations. The goal of all TG lowering therapies must be to reduce either the risk of STG-AP or ASCVD. Several guidelines recommend therapeutic lifestyle changes as first-line treatment and not the pharmacological therapy of STG. These changes include low saturated fat, carbohydrate controlled diet, combined with alcohol reduction, smoking cessation, and regular aerobic exercise, correcting the secondary factors and optimizing lifestyle choices, including dietary modifications, is important before starting drug treatment. And almost 70% reduction of serum TG levels has been shown to occur by combining weight loss through calorie restriction, alterations in macronutrient composition, and increased energy expenditure. And also ESC, EAS guideline for the management of dyslipidemia, similar to AHA, ASCC guidelines, recommend considering the use of TG lowering drugs only in high-risk patients when lifestyle measures fail to lower TG levels. In conjunction with intensifying efforts as lifestyle changes, fibrates, omega-3 fatty acids, and niacin are used to treat severe STG. So lifestyle intervention and adopting healthy habits are cost-effective and safe and have multiple additional benefits with sustainable, long-lasting, overall beneficial effect on health. Unlike medication, they do not have any adverse effect and do not require dependence. Thank you.
Yes, thank you, Dr. Sudhir. Nice presentation. Now, Dr. Ajay is there to rebut you. Please come here. You can stay here, no problem.
Thank you, Dr. Sudhir. And he made my job extremely easy by showing 4 slides. The first slide which he showed that it was written that hypertriglyceridemia should be treated with drugs. Then he showed 2 other slides where he mentioned that more than 200, the value is more than 200, we should start using fibrates as one of the therapies to manage high triglyceride levels. So lifestyle modification is one of the most important pillars of management of most of the non-communicable diseases. There is no doubt about it, including weight loss. There is no doubt about it. But if you have a very high triglyceride level, it needs to be treated with drugs. And we have drugs. He showed so many side effects of fibrates, but then there are, again, we have so many side effects of statins as well. So it doesn't stop us from using statins at all. We use statins in our patients. We have to be judicious, we have to be careful. We should know when not to write, that is very, very important. But then high triglyceride level, as he has shown in some of the slides, in 5 or 7 of the slides, Dr. Sanjay and me was watching, that you can use pharmacological intervention after 200, the value of TG is after 200. So I thank him for that. Thank you so much. In one of the slides, he said 500 as well. Well, do not wait for 500. Do not wait for 500. Do not let your patient go to the inpatient. Do not let him become an inpatient warder. Please treat his triglyceride levels. We have good drugs, safe drugs. Niacin has side effects. We have, in my center, I have almost about 17,000 patients since last 12 to 13 years who are on fibrates, and they are doing extremely well. I have just one patient who had fibromyalgia. He went to NIMHANS, Bangalore. He was diagnosed with the cause of his fibromyalgia was fenofibrate. Otherwise, since last 13 or 14 years of my diabetes practice, I'm yet to see a patient who has come back to me after taking fibrates with body ache or any other complications. Thank you so much.
Actually, I have seen in my practice that most of the times when we use lifestyle modification as primary modality to reduce TG levels, these are very much effective and people are satisfied, and it has long lasting effect. So I think lifestyle modification is naturally the first line of treatment to lower TG levels. And if we have to, as he said, if we have to add the drug therapy, it can be started only after TG level of 500 or more than 500. So I think I use personally prefer to use supplements such as IC and this fish oils to lower TG levels very effectively. And as I have shown that there is no CV benefit upon lowering the TG levels through drugs, fibrates.
So the debate was, the debate was given whether to give anti-drug to reduce triglyceride level. So now the management of triglyceride, the primary management will be to reduce the secondary risk factors. Number 1, lifestyle modification, weight loss, reduction on alcohol consumption. I will come in, one question is there. Just can you define how much alcohol patient can take having hypertriglyceridemia?
None.
Whether it depends on the level of triglyceride or not?
None. Not even a single drop of alcohol is recommended.
He's spoiling all the fun of the conference, I'm telling you. He's spoiling all the fun.
It depends. Second, so if you have to reduce triglyceride, you have decided, you have controlled your LDL level, yes, non-HDL level. Now you have to start medicine to reduce triglyceride. Which drug you would prefer? Whether you go for omega-3 fatty acids or you go for fibrate. Which one is better?
If I will have to address other lipid particles, such as LDL level, then I will definitely go with statins.
Statin is already there, number 1 choice. You have to give statin. There is no point of giving above statin what you are going to give.
I think they have finished their talk. Would you like to give one-line summary?
Yeah.
You, Dr.
Myself.
Sanjay.
To summarize is, both of them has done their job, wonderful job. So a big thank you to both of them, and let's clap for them.
Okay.
And the message should go, the right message should go to the audience.
Yeah. Now, as there should not be any further questions or any comments, but as chairman of the scientific committee, it is my privilege to give the final comment because I have chosen this topic. The current concept is very, very clear, and please take it. There is no controversy in this today regarding the use of the treatment of hypertriglyceridemia. If the triglycerides are more than 500, you treat them with statins and fibrates to reduce the risk of acute pancreatitis, not cardiovascular risk.
Right.
Stop. Anything less than 500, there is no treatment except for intensive lifestyle modification, statins, intensify statins, add ezetimibe. The role of fibrates is zero if the triglycerides is less than 500. And Dr. Chabra talked about the prominent trial. The results have already been published. And let me tell you, the pemafibrate was the last nail in the coffin of the fibrates as a treatment for hypertriglyceridemia less than 500. There was one indication where fibrates were used in one of the trials that was very high triglycerides, say around 300, 400, and a very low HDL. But then that was the only subset of patients which showed a reduction in the cardiovascular risk, but even that was not statistically significant. So if you're looking at reduction in the cardiovascular risk, fibrates have no role to play today. Thank you.
Thank you, sir, for some that. Thank you.
Dr. Virmani, sir, please wait. In one line, take-home message to the audience. Just one line.
Already given. There is no role of fibrate below 500.
Treat triglycerides only over 500. Below that, the patient will panic, you don't panic.
Sir, one comment about reduce IT. Any comment on reduce IT trial? Reduce IT trial.
Sorry?
Reduce IT trial.
Reduce?
IT. Icosapent.
Oh, that study has been blown to ashes. There were a lot of defects in that study. Icosapentine is no longer recommended in the treatment, and the dose was, even for omega fatty acids, the dose is more than 4 grams twice daily, not possible to take. So that is out of question. So again, we go back to square one, lifestyle modification, intensive lifestyle modification, and very intensive lifestyle modification. That's all.
Thank you, sir.
Thank you.
Thank you, sir. Once again, put your hands together. Big clap for all of the speakers, moderator, and of course, Dr. Virmani, sir. May I request our moderator, Dr. Sanjay, to please hand over the memento to both excellent speakers, to Dr. Ajay Chabra. सेंटर पे आइए, सामने आइए. Claps, please. Thank you. Memento to Dr. Sudhir from moderator. And finally, memento from both speakers to our moderator. Thank you so much. Moving ahead to the next session, may I request the chairperson for this and the last session of the evening, Dr. Rajesh Thakur, Dr. Arun Kedia, and Dr. Imran Shaikho to please come on the dais. Can we have Dr. Imran Shaikho, please? Is he here? I think he is not there. Okay. So in this session, we had 3 speakers earlier, but at the moment we will have only 1 speaker. That is our very own Dr. Mandar Shah. He is going to speak on sudden cardiac death, a very relevant topic. We read every day in and out. आज जिम में ये हो गया, कल यंग को ये हो गया, कल एल्डरली हो गया, and we all are perplexed कि a person without any symptom, a young patient, how they are going into sudden cardiac death. We all are excited to hear from Dr. Mandar Shah, and I'm sure he is equally excited. Thank you so much to the chairpersons.
Good evening, everyone. Now we are in the today's last session. And we are going to have a tremendous presentation from Dr. Mandar Shah. He will be speaking on sudden cardiac death. In SCD, without intervention, it could lead to death. So he will brief us about the SCD. or syncope. Dr. Mandar Sahab, please.
Slides, please.
Slides.
Thank you so much, all the organizers, for having me on this August podium. It's a great honor and a privilege indeed. And also, I thank Dr. Virmani to make slight tweak in the topic. So rather than speaking only on sudden cardiac arrest, I thought I will talk on this topic. Fainting could be fatal because syncope and sudden cardiac death or sudden cardiac arrest go hand in hand. And it is very important for us as physicians or clinicians to know which of the patients who have fainted deserve more attention, which are malignant causes of syncope, which require more attention and which can be ignored by themselves. So I will club sudden cardiac death with syncope and come up with this topic: fainting could be fatal. So I have no disclosures. Syncope. So what is syncope? Definition of syncope. Am I audible actually? Last benches? Okay, fine. So definition of syncope encompasses 4 components. One is a transient loss of consciousness with loss of postural tone, with spontaneous and full recovery, without any prolonged confusion. So each of this component of syncope is very important, and that is the reason why I've split it into 4 parts. So syncope is actually defined as transient loss of consciousness with loss of postural tone, with spontaneous and full recovery, without any prolonged postictal confusion. So impact of syncope is huge. 40% of all of us will experience syncope at least once in our lifetime. And 1 to 6% of hospital admissions account for syncope. 1% of emergency room visits per year. What is more important is major morbidity is 6%. What is major morbidity? Something like patients falling out of syncope and having a fracture or having a road traffic accident, vehicular accident because of syncope. So this is 6%. So impact of syncope is significant. But all syncope is not the same. And syncope is not one disease, one entity, as all of you know. It is just a manifestation of something underneath, and we need to know what it is. For that, we need to be able to classify syncope. So the commonest cause of syncope is reflex or neurally mediated syncope, which could be vasovagal syncope, mediated by emotional stress, fear, pain, blood, phobia, etc. It could be situational syncope, such as cough syncope, defecation syncope, micturition syncope, and things like that. Or neurally mediated could be because of carotid sinus hypersensitivity. And this entire spectrum is a benign cause of syncope. Another benign cause of syncope is syncope due to orthostatic hypotension. Now, as name implies, orthostatic hypotension is whenever patient stands up as compared to supine position, there is drop in blood pressure and reduced cerebral blood flow leading to syncope. So this could be because of either primary or secondary autonomic failure, like for example in patients with Parkinson's, diabetes, amyloidosis, etc. Or more commonly, it could be because of drugs that we commonly use in our day-to-day practice, like for example diuretics, antihypertensives, prostate medications. So because of this, postural hypotension can be there. And for us cardiologists and for you physicians also, this is very important. Occult GI blood loss. Occult blood loss in gastrointestinal tract. Most of our patients are on dual antiplatelets. And one of the very prominent common causes, but very less recognized, is syncope because of orthostatic hypotension, because of occult GI blood loss. So whenever we get a patient with orthostatic hypotension, we always make this as a routine to send stool occult blood. So these were 2 benign spectrums of syncope. The malignant spectrum is cardiac syncope. And cardiac syncope could be because of arrhythmias, tachyarrhythmias, bradyarrhythmias, or it could be because of structural abnormalities, like for example, hypertrophic cardiomyopathy, or valvular heart disease, severe aortic stenosis, for example, or pericardial diseases, tamponade, etc. And of course, it also encompasses other causes such as pulmonary embolism, aortic dissection, etc. Now, it is very important that we are able to differentiate between these different types of syncope, because the prognosis, the management, the approach to the patient will change based on the cause. As you can see over here, in the top two lines, the yellow and the black lines are because of vasovagal syncope or no syncope, and the red line is cardiac cause of syncope. On x-axis is time duration in years, and on y-axis is probability of survival. So, as you can see, if patient has vasovagal or other benign cause of syncope, and if patient has no cause of syncope, long-term survival is practically the same. So vasovagal syncope and patient without syncope, there is no change in mortality, there is no change in long-term survival. But cardiac cause of syncope, there is significant rise in mortality, significantly less survival as time passes. 6-month mortality rate is greater than 10%. Cardiac syncope doubles the risk of death. And cardiac syncope can be harbinger of sudden cardiac death. So it's very important that we differentiate cardiac syncope from rest of the causes. And in my slides, I will give some tips to identify and differentiate between the two. So whenever you have a patient with syncope, how should you approach? So first of all, you should have a diagnostic plan. And in your diagnostic plan, the initial assessment is of utmost importance. These 4 or 5 points: detailed patient history, an elaborate patient history, physical examination including peripheral pulses, including carotid sinus hypersensitivity, including auscultation for heart sounds, etc., ECG, and supine and upright blood pressure. So once you take these 4 things meticulously, then 80% of your diagnosis is made. And rest of the sophisticated investigations, including Holters, event recorders, ILRs, etc., are only going to serve you 20% of your cases, just to refute or to prove in the diagnosis. So, because history is so important, I'm going to spend a little bit of time on detailed history. So, always make sure that you take eyewitnesses account into account. You should always interrogate the eyewitness whenever you are taking history. Ask for symptoms at onset, ask for medications, ask for circumstances that led to the event. You should ask him, narrate the entire sequence of events, what exactly happened, like a story. And then of course you should ask about family history, you should ask about past medical history. Family history of sudden cardiac death is very important, not to miss that. And from your history, most of the times you will be able to get to diagnosis, whether it is neurally mediated syncope, wherein patient will say that he had fainting following unpleasant sight, sound, there will be no cardiac history, or maybe patient is standing in a crowded place, or more commonly, patient has got up in middle of the night to go to pass urine and he has fainted. So these are all suggestive of vasovagal syncope. Syncope due to orthostatic hypotension, again, is very obvious. Patient will say that I was lying down, I stood up and I fainted. Often there is temporal relationship with medications. So patient, you'll have to ask specifically, but then patient will say that, yes, recently I was started on prostate medications, or say medications like diuretics, antihypertensives, etc. And cardiac syncope, there may be a presence of significant structural heart disease, or there may be a family history of sudden cardiac arrest. Syncope that occurs with exertion or in supine position is never benign, so you should always look for suspect malignant causes for the same. So the most useful tool for evaluation in case of syncope is, by now you should have realized, history. Second most useful tool is history, and third most useful tool is also history. So please spend enough time on patients with syncope to evaluate a detailed history. In addition, echocardiography is very important. We do echocardiography in all patients with syncope because if there is any structural abnormality, then our line of thinking changes. And then there are other diagnostic tests. Like I said, they will only help you to confirm or refute your diagnosis which you have made on history and physical examination. So head-up tilt test was used once upon a time very commonly. We used to do it in our OPD also commonly, but it has got lots of fallacies, lots of false positives, false negatives. So we have started taking head-up tilt test with pinch of salt. And this, of course, is extended Holter, external event recorder, which is a better substitute for Holter, because Holter, what happens is only during those 24 or 48 hours when you have put Holter, if any event has to happen, only then it will get picked up and you will be able to diagnose. Many times, most of the times, event may not happen when you have put on Holter. So it's, the sensitivity increases if you put a 5 days or 10 days external event recorder, which now is very easily available and quite an affordable cost. And the least useful tools for evaluation are CT scan, MRI, EEG, carotid Doppler. And unfortunately, whenever we have a patient with syncope, the first investigations that we do are these. See, let me tell you, there is no such thing as a cerebral cause of syncope. The only cerebrovascular cause of syncope is subclavian steal syndrome, when there is significant subclavian stenosis and patient has significant exercise of that arm, and then subclavian steal occurs. Otherwise, even if you have bilateral carotid artery stenosis, say for example, that is not going to cause syncope. I've mentioned this time and again. This has been preached to us by my mentors, Dr. Yash Lokhandwala, Dr. Narsimhan, who have been telling time and again that even if you do carotid Doppler and even if you find significant stenosis, that is an incidental finding that will not give rise to syncope. Significant carotid artery stenosis will give rise to TIA, transient ischemic attacks, which is focal neurodeficit like stroke, which is going to remain for a short period of time and then going to recover. Transient ischemic attack will not lead to loss of consciousness, so TIA is not a differential diagnosis for syncope. And all these tests, CT scan, MRI, carotid Doppler, are only for satisfaction of patient and satisfaction of physician, mental peace, but they have got no scientific rationale. The only exception is when history-wise you are not sure whether it was seizures or syncope, and 90% of the times with good history you will be able to easily differentiate whether this was seizure or syncope. If not, then you are justified in doing this test. Otherwise, in overwhelming majority of patients, do not do CT scan, MRI. I never do CT scan, MRI, EEG or carotid Doppler to any of my patients coming with syncope. This is one take-home message I just want every one of you to take home. Then what about role of EP study? So in 95% of cases, there is no role of EP study. So there is an exception in 5% of cases when you are suspecting tachyarrhythmia related, tachyarrhythmia, not bradyarrhythmia. Whenever you are suspecting tachyarrhythmia related syncope and you are not able to prove it on ECG, then you've got a role. Like this was a paper which I had published along with Dr. Yash Lokhandwala while I was doing my residency. A 69 years old gentleman had numerous episodes of syncope. Head-up tilt test was positive and he was diagnosed as neurocardiogenic syncope. But lifestyle, dietary, pharmacological measures were all ineffective. Then on detailed history, he said that every time whenever he gets syncope, it is preceded by palpitations. So then we took him for EP study, and EP study showed easily inducible AVNRT, supraventricular tachycardia. And as soon as supraventricular tachycardia would start, the blood pressure would significantly drop. And that was the cause of syncope. We treated his AVNRT, ablated, and subsequently he has never had even a single episode of syncope. So in such cases, EP study will help. But again, that is only 5% of cases. 95% of cases, it will not help. Whenever you've got some moderate LV dysfunction, 40-45% ejection fraction, and you're not sure whether there is ventricular tachycardia as the cause, then for inducing ventricular tachycardia, you can do electrophysiological studies. So very important red flags for syncope. These are the things which you should all look for whenever you are dealing with a patient with syncope. Syncope resulting in injury. Syncope during exercise. Syncope in supine position. Suspected or known structural heart disease. ECG abnormalities like pre-excitation, long QT syndrome, bundle branch block, bradyarrhythmias, tachyarrhythmias, old MIs. So all of these things. Family history of sudden cardiac death. Frequent episodes, which is defined as more than 2 episodes of syncope per year. And implantable patient already has implanted defibrillator or pacemaker and he develops syncope, you should always suspect pacemaker malfunctioning. And high-risk occupations like bus driver or pilot, obviously even benign causes of syncope, you would want to be extra careful with these. So these are the red flags. All of you should remember these red flags. When neither of these is present, you can safely assume that you are probably dealing with a benign cause of syncope and then you don't need to worry much. All that glitters is not gold. Similarly, all that convulses is not epilepsy. To make my point, I'll show you an example. Here we were dealing with this patient in TMH, 74 years old gentleman with recurrent seizures, and the patient was following up in neurology OPD. In December 15, he had seizures. He was started on anti-epileptics. EEG was done, everything was done, sent home. And 2 days later, on 2nd of January, he came with another episode of seizures, and this time, complete heart block was documented on ECG. We went back at that time, and 31st December, 2 days back, when patient was admitted with so-called seizures, we saw the ECG, and that ECG showed trifascicular block. So this patient was getting paroxysmal episodes of complete heart block, which were wrongly being labeled as seizures, epilepsy, and was being treated with anti-epileptic drugs. So all that convulses is not epilepsy, please keep in mind. Another case, this was while I was in
Sir, you're exceeding your time, sir.
Okay, I was told that.
Okay.
Go ahead. Sure, thank you. So another case that we had was of patient with so-called multiple seizures, MRI done, EEG done, epileptologist's opinion taken. One fine day, he continued to get seizures. One fine day, when patient was admitted on ventilator, on inotropes, a resident noticed that there is a small run of ventricular tachycardia, polymorphic ventricular tachycardia on monitor, so he got cardiology reference. We did his echo was normal, ECG was normal, but while we were going through his previous past records, we found this. So all of you could recognize with this clinical history, this is Brugada. So this is Brugada syndrome. Intermittently, some of his ECGs did show Brugada in the past. So we went ahead and put the patient on AICD. So he was again wrongly labeled as a case of epilepsy. So this is one more favorite slide of mine. I always show this in many of my lectures. This is a tree until I tell you that there are some faces hidden into it. As soon as I tell you that there are faces hidden, you will start seeing lots of faces over there. So what the mind doesn't know, your eyes cannot see. So train your mind to look at subtleties in ECG, prolonged QT, Brugada, epsilon waves, all of these things you should learn to look at in ECG. Coming to sudden cardiac death, syncope and sudden death are the same, except that in one, you wake up. This is the statement which I took from Annals of Internal Medicine way back in 1978. The statement holds true even today. Coming to official definition of sudden cardiac death is witnessed cardiac arrest within 1 hour after onset of acute symptoms, or unexpected unwitnessed death in a patient known to have been well within previous 24 hours. And 80% of cases, sudden cardiac death is because of coronary artery disease. 15% of cases, it is because of LV dysfunction and cardiomyopathies. And 5% is because of channelopathies. Again, mode of death, in 88% of cases, it is arrhythmic cause of death that leads to sudden cardiac death. Again, out of these arrhythmias, 90% of arrhythmias are tachyarrhythmias, ventricular tachycardia or ventricular fibrillation. And whenever you get a patient with sudden cardiac arrest, before the patient progresses to sudden cardiac death, you have to intervene fast, and in majority of cases, it is defibrillation, and you don't have time. So as time passes, within 8 or 9 minutes, probability of survival will be 0. So you have to be very rapid, very fast. For that, the best tool that is now available is AICD. All of you know how AICD works by 2 ways, either by anti-tachycardia pacing, like is seen in the top ECG, or by delivering a cardiac shock. So these are just the algorithms to show which all are the patients who should be implanted with AICD. For want of time, I think I should cut short. Thank you.
Thank you, Dr. Mandar. A very nice elaborated presentation on syncope or SCD. Any questions from the audience? Any queries?
This is not a question, this is just a comment. Dr. Mandar, I think sudden cardiac death is now one of the most important clinical problems that we are facing. And even syncope, as you very rightly said, it's high time that CPR, how to do CPR, should be propagated in every nook and corner to each and every citizen, so that emergency treatment can be given by even a non-health care worker.
Very rightly said, sir. So one of the aims is to make every household of India, at least one person, be CPR trained. And we have already begun the efforts, sir, even in Jamshedpur. We have taken this initiative, and Tata Steel has been imparting CPR training sessions to schools, colleges, railways, and multiple places. But very rightly so, everybody of us should know, being doctors, CPR right way, but every household should be trained in CPR. Yes, sir.
Timely intervention is very much needed in that condition. Timely intervention, otherwise we can lose the patients.
And I think there should be a registry of sudden cardiac death also, because most of the patients and the family members will not reveal the history of sudden cardiac death unless until you ask. So
yes,
if we have a registry, or if we make people aware about sudden cardiac death and the importance of the history, then probably in the subsequent generation or in the subsequent relatives, that could be useful for diagnosing conditions.
Absolutely, sir. Fully agree.
Yes, please.
Can you please give mic to Dr. Nivedita, please?
You said for neurocardiogenic syncope, HUTT has fallen out of repute. So what can be the next possible investigation?
It is always clinical history. Neurocardiogenic syncope is almost not 80%, 95% of the cases is diagnosed by detailed history and physical examination. You don't require a head-up tilt test. Unfortunately, lots of fallacies with head-up tilt test. So even a normal person who does not have neurocardiogenic syncope, you can induce syncope by giving him sorbitrate and making him upright suddenly. So lots of false positives and false negatives with the head-up tilt test. So it is okay to use head-up tilt test sometimes when you have exhausted with, you are not finding any cause, then to this thing. But that is not to be used as a routine investigation of choice.
Thank you.
In this time of evidence-based and legalities, how can we stamp someone without an investigative modality, just on the basis of clinical?
Yes, this is a proven fact that for syncope, like I said, and it's mentioned in books, it has got full validity that the most important tool in your this thing is history and your physical examination. It will absolutely stand the test of time. You can safely defend yourself even in court of law.
Okay, thank you.
Dr. Nivedita is not only taking history, is also documenting it. That is more important. Once you write on the case sheet, you have documented the history. That itself is solid medico-legal evidence.
Thank you so much. So we come to the end of the session today. Please wait. Please wait. Don't run away, Dr. Mandarsa. I will not allow you to run away so fast. So, loud, big, you know what. Thank you so much. Thank you, Dr. Mandarsa, for an excellent talk and a burning topic. Thank you, the chairpersons. May I request now chairpersons to please hand over the memento to our speaker, Dr. Mandarsa. एक मिनट रुक जाओ यार. I would request Dr. Mandarsa to please hand over memento to both the chairpersons, one by one. To Dr. Rajesh Thakur. Acha, okay. To Dr. Kedia. Thank you. To Dr. Rajesh Thakur. Thank you so much. So we come to the end of today's session. Two important announcements. I welcome you all for the dinner. We have got two bars. The bar nearer to me now, to the desk, it is for the faculty, and the bar at the back, it is for the delegates. Number one. Number two announcement, please, no matter whatever you eat, whatever you drink tonight, please be sure that tomorrow morning we all are here at 8:45 a.m. Thank you so much. Please be on time today and enjoy your drink, and we are going to have a ghazal night now. Please enjoy the ghazal night. Thank you.